mics.
Yeah.
You can start now.
Okay, I'll wash my hand. I introduce myself. I take permission from 6-year-old boy, and then his parents, and then I like to have a good exposure, maintain his dignity and privacy. So I'm looking at the child from a distance and looking at his general well-built. Does he look well-grown for his age?
No, he looks little less. His height and weight is little less.
Okay, and then I'm looking at the general appearance. Does he look well-looking or sick-looking?
He's well looking.
Okay, and then I like to see his face for any dysmorphic features. Do I see that?
No.
Okay, and I'm now looking at the surroundings for any medications or any clues. Do I find anything?
Don't ask questions, huh, Dr. Amit? No, there is nothing. Just explain. Yeah.
Okay, so now I'd like to move close, and then I'm starting my examinations from the hands, and I'm looking at both the hands, and from the universal cue, both the limbs looks quite wasted on appearance, and then I'm looking at the nails to see for evidence of nail clubbing. Do I see the clubbing?
No, don't ask questions. I was saying they will not allow questions, huh, Dr. Amit? Okay, no clubbing.
No,
Okay.
but he should ask what he will see in the hand.
No. I'm seeing on the hands for clubbing, for pallor, for icterus. Like what?
Okay, I got it. So I'm looking at the hands for the nail clubbing, and then for peripheral cyanosis, and I'm looking at the palms for pulmonary edema, and I'm looking at the dorsum of the hands to look for any multiple scars due to the IV
Multiple
cannulation.
IV cannulation scars are there.
Okay, so I'm at this point of time, I'd like to feel the pulse.
110 per minute, regular.
Okay, and then I'd like to ideally take the blood pressure at this moment. I'm looking at the, I'm going towards the face. I'm looking at the eyes to look for any jaundice on the bulbal sclera, and on the palpebral conjunctiva, I'm looking for the pallor. Do I see them?
No.
Okay. And I'm looking at the mouth to see for the central cyanosis and any mouth ulcers, dental hygienes, and the palate. Do I see any abnormalities there?
No.
Okay. I'm looking at the neck and the entire chest and the abdomen. And do I see any scars on the neck? Oh. Okay. And I'm looking. Okay. I'm looking at the abdomen, and the abdomen seems to be distended, and then the flanks seem to be full on the right upper quadrant.
Yeah.
Yeah, and then I'm looking at his back to see if there is any scars or
No.
no. Okay, so I'll warm my hands before touching the abdomen, and then I'll make sure that the child is not in pain. I'll explain him that I'm going to touch his abdomen. So I'm starting from the right iliac fossa regions and moving on the anticlockwise directions, and ask him to breathe in and out with his deep inspirations. I'm palpating along the edge of my right finger, and then moving upwards with his deep inspirations to feel for any mass that I feel as I move towards the right hypochondrium. Do I feel the mass?
2 centimeters below a soft liver.
Okay, so I'm moving my hands towards the left towards the left hypochondrium, and then do I feel any mass there?
Yes, as per the universal cue also there is a mass that is felt.
Okay, so I'll start palpating for the spleen from the right iliac fossa regions toward the left hypochondrium diagonally with each deep inspirations, and then trying to feel the tip of the spleen with the tip of my fingers as I move.
There is a large spleen which is across to the umbilicus, and you can even feel the splenic notch.
Okay, is it, how is the consistency? Okay, is it tender? I'm looking at the face.
No, not tender.
And then I like to I like to feel for the I'm like to see for the fluid to look for the ascites. I'm palpating from up to look for any shifting dullness. Do I see that?
How will you do shifting dullness?
Okay, so I'll be doing the percussions from the in the midline, coming from the giphisternum towards the umbilicus, and then from umbilicus I'll move percussing towards the lateral side, and then ask the child to turn on the either side and to see if to listen to the percussion note.
Shifting dullness present.
Okay, I like to assess whether there is a fluid thrill or not by putting one hand in the midline and then percussing on the right side and feeling with the left hand on the other side. Do I feel the
fluid thrill absent?
Okay. Now I like to auscultate over the splenic area to hear for any brew.
No brewing.
Okay.
6 minutes finish. But if you want to ask anything, you can.
So I'd like to complete my examinations by taking his height, weight, and plotting on appropriate percentile charts. And then I'd like to examine his for the pedal edema and complete my examination by doing the genital examinations as well.
Okay, please present your case.
So 6-year-old child, he looks thin for his weight and age. And on the examinations, there is multiple scar mark on the dorsum of the hands.
Okay.
And then on abdominal examinations, there is 2 centimeters soft enlarged 2 centimeter enlarged liver, and then a massive splenomegaly crossing the midline and with ascites.
Okay. So what will be your differentials?
My differential diagnosis would be it could be a hemolytic anemia, could be hereditary spherocytosis, or it could be a thalassemia, or it could be a metabolic disease such as Gaucher disease, or it could be a malignancy.
Okay, I will just interrupt. Why will there be ascites in hereditary spherocytosis? Did you ask whether there are dilated veins? This picture does not show, but dilated veins are also there on the abdomen. Oh. And why will there be ascites in hereditary spherocytosis and thalassemia?
Because of the cirrhosis of the liver in
hereditary spherocytosis will it have cirrhosis?
In hereditary spherocytosis, there won't be cirrhosis.
Any other features of thalassemia? That thalassemia can have cirrhosis. Did you get any other thalassemic features in this child?
I didn't ask.
And there was generally there'll be hepatomegaly will also be equally there in thal. You asked me for dysmorphic faces. I said no.
Yeah, but I could have asked for the hemolytic faces.
Yeah, but even that's I kept that in mind. It's no. There is what about liver? Will the liver be so shrunken in despite of the cirrhosis in thalassemia? Even if there is cirrhosis of the liver in thalassemia because of iron deposition, still there will be quite a big component of hepatomegaly. Did you measure the liver span?
No, I didn't measure the liver span.
Yeah. This is splenomegaly with ascites. So what can your DDs be with splenomegaly with ascites?
So it could be a portal hypertension.
Excellent, portal hypertension. So what are the causes of portal hypertension you know, and where will you classify this child?
So this could be a, the portal hypertension could be a prehepatic, hepatic, and posthepatic.
Very good.
And then prehepatic, it could be a portal vein thrombosis.
So which one is this? Which one would you classify this and why?
So this could be a portal vein thrombosis.
Means the prehepatic one.
A pre-hepatic one without the hepatic involvement.
Very good. So what are the causes of pre-hepatic? You said portal vein thrombosis. So why will portal vein thrombosis occur? Do you know any predisposing factors?
Yeah, it could be the omphalitis.
Very good. Yeah.
Or it could be a procedure done by umbilical vein or catheterization.
Arterial catheterization. Okay.
Or it could be any thrombophilic conditions which could lead to the
Can you
hypercoagulation.
name a few thrombophilic conditions?
So protein C and S deficiency, antithrombin 3 deficiency.
Very good. Factor 5 laden mutation and homocysteine. Right? Okay, so how will you manage? We'll discuss hepatic, post-hepatic later. How will you manage this case?
So this kid needs a approach with the multidisciplinary team. Or managing the first primarily the medical management and as well as the.
Will you investigate before the management?
So we'll investigate with the complete blood count.
What will you see in the complete blood count?
So there could be a pancytopenia because of the hyperestrogenism.
Very good. Yeah.
And we'll be doing the liver function test as well, where and then coagulation profile, and doing the renal profile as well.
Okay.
And then doing the urine dipstick.
Okay. What will tell you this is pre-hepatic portal vein hypertension?
Pardon?
Okay. Which test will tell you that this is a portal vein hypertension because of pre-hepatic cause?
Okay, the scan, the USG scan will show.
Yeah. USG with? Only USG?
USG with Doppler.
With Doppler. Right. And okay, then how will you manage?
So management of this would be a multidisciplinary team approach involving the pediatrician as a central role and managing and then we'll be consulting the pediatric hepatologist if available. And then the treatment also depends upon the cause and growth.
Okay. This child is bleeding, having the esophageal variceal bleed. How will you manage? I think this was the question asked in the exam.
So esophageal varices management, we need to stabilize, assess the airway, breathing and circulation of the child and manage accordingly. And then the first primary important thing is that to secure an IV cannula, with more preferably 2 sides, and then sending the blood for the cross matching because the child may need the blood transfusions. And then we'll be starting with the pantoprazole or the proton pump inhibitor, and we'll be giving the vitamin K IV, and then we'll be arranging the blood products like fresh frozen plasma, and then the packed red blood cells for supportive treatment. And then in terms of medical treatment, we'll be giving infusion of octreotide, which will.
What's the mechanism of action of octreotide? Even this was asked.
So this will helps in the vasoconstriction of the splenic circulations.
Splenic vasoconstrictor. Yeah.
And if the bleeding does not get better with the medical management, we need to go for the surgical management and do upper GI endoscopy and then ligation of the occipital varices or sclerotherapy could be the other options. And I'd like to involve the pediatric gastroenterology team or the hepatologist team and the surgeons even if they can go for the surgical modes of treating the occipital varices, such like tips.
What are the complications that this child can go into?
So the complications can be that the child can have the ultrasensorium going into coma,
hepatic
encephalopathy, and then it can affect the kidneys, causing the hepatorenal syndrome.
Very good.
It can affect the lungs as well, and then causing the
hepatopulmonary syndrome.
there is chances of having infections on the ascites. Spontaneous bacterial peritonitis can be there. And because of the bleeding, the child can go into shock. And then because of this condition, the growth and nutrition of this child will be hampered.
Yeah. What is the triad for portal hypertension? 3 things will be there and
portal hypertension is there is splenomegaly, ascites,
and portosystemic shunt.
portosystemic shunt.
Yeah. Okay. And fine. Just to complete this discussion, what are the hepatic causes of? Why is this not hepatic? Portal hypertension. Why did you say it's pre-hepatic?
Pre-hepatic, right?
You said pre-hepatic. Why did you say pre-hepatic and not hepatic or post-hepatic?
Okay. So in this child, there was no jaundice.
Very good. No jaundice. And
then there was no features of there was no features
hepatomegaly also.
Yeah, no hepatomegaly.
I mean, no hepatomegaly, no liver cell failure, no jaundice signs. So what are the causes of hepatic causes of portal hypertension?
The causes can be divided into infectious causes, metabolic causes, nutritive causes, and the malignant causes.
Yeah.
So most of the hepatic causes are metabolic causes, just like Wilson disease, alpha-1 antitrypsin deficiency, galactosemia, and Sturge disease.
Yeah. Galactosemia and tyrosinemia, cystic fibrosis also. And otherwise, the cirrhosis of the liver that can take place because of this. You said metabolic causes. Infectious could be torch in a small child, hepatitis C and B in an older child. Very rare, but that is. And toxins also. And what are the pre-hepatic causes?
Pre-hepatic causes.
No, post-hepatic, post-hepatic.
Sorry, post-hepatic, post-hepatic.
Yeah. Post-hepatic is causes the constrictive pericarditis. And the other is the Budd-Chiari syndrome.
Okay, very good. So how will you differentiate hepatic from post-hepatic?
Hepatic from post-hepatic.
Post-hepatic. Both will have hepatomegaly.
Yeah.
Both will have ascites. Both will have jaundice.
So I think it's with the palpation, the liver can be soft.
Very good. Soft liver. The liver consistency will be soft and
soft and pulsatile liver.
Tender. Soft, tender. And there will be engorged veins also. In constrictive pericarditis, we can get an engorged vein at this point of time. And the Budd-Chiari will have a lot of ascites and distension of the veins in the front and the back. So this is one way we can, although it's difficult, but still we can, this is the thing. Just one sec.
Finished or still?
No, I'm just, that's it, I think, yeah. Other things, even I'm not clear what are this about hepatic NKF management if they ask. I'm trying to search, I'm sending to Hunt.
Lactulose they give? Lactulose.
Neomycin, lactulose, everywhere is given. Yes. Protein restriction is given, but I'm not sure. I've not read this in any of them.
Low protein diet, yes.
Yeah. Thank you, Dr. Amit.
Thank you, Dr. Muzda.
So basically, this case, like it's an isolated splenomegaly, So the thing which actually hits is the ascites, which was mentioned. So the ascites makes the diagnosis go towards the other place. Otherwise, it either to be only splenomegaly with no ascites, but as it was rightly said, hereditary spherocytosis comes as the first bleeding. Such a big spleen. which will be the second DD for such splenomegaly? Of course, then we have to go with like that, like infectious causes. Okay, chronic infections like malaria, Kala Azar. These are the ones which can cause such a big spleen without any ascites. Hereditary spherositis comes high in the line. The very closest differential to hereditary spherositis is autoimmune hemolytic anemia. It is very similar. It's very difficult to differentiate between the both of the two. Until and unless you do a direct Coombs test and you come to know that it is an autoimmune hemolytic anemia, or you do a polyacrylamide gel electrophoresis and you come to know it's a hereditary spherositis. That's the closest DD for a hereditary spherositis. So you can see, say, or we can say this: if this child is unwell, a splenic sequestration crisis which has come in a sickle, or a sickle thal. However, there is no hepatomegaly probably is just coming up, so that comes down the lines. Or storage disorders, but storage disorders also have a big component of hepatomegaly. Isolated splenomegaly is not so much there. That's why we are putting, we can say hereditary spherositis, autoimmune, and the infectious causes high up. Any other
So,
input?
Dr. Mujna, what was the age of this child? Sorry, I was not in between.
6 years.
6 years. So if in this patient we are not getting spleen and we are getting pallor and jaundice, suppose, so this will be by this stage 6 years sickle cell will get autosplenectosis, right?
Yeah.
If we get both of them, then it will be most likely thalassemia, liver and spleen both. So suppose with pallor and jaundice.
Hemolytic phases,
yeah.
but no ascites.
If we are
no ascites. With hemolytic phases and ascites and hepatosplenomegaly, then this is a thalassemia which has gone into liver cell failure because of the cirrhosis and iron deficiency, and now this has gone into portal hypertension. So that is going to
and
be
only so, and if
Dr.
only spleen, mostly
sorry,
only
sorry, this hematochromatosis due to either iron, it all presents only with hepatomegaly. This is the only differential that presented with cirrhosis, but only with hepatomegaly.
Which, please pardon, Dr. Yasser, which hemochromatosis you're saying?
Yeah, means this is iron deficiency, na? Due to iron deficiency deposition causing the thalassemia. If you say if it could be
no, I'm saying thalassemia per se has this extra hepatic, extramedullary, extra hematopoiesis. Okay, so as per se they will have hepatosplenomegaly. Okay, so but over a period of time, this iron is getting deposited in the liver, is causing a component of cirrhosis, due to which there is liver cell failure.
That is hepatomegaly, not hepatocirrhosis.
No, that will be hepatomegaly. That will not have an That's what I'm saying. Hepatomegaly with thalassaemic phases, with ascites and features of portal hypertension, then we can safely say this is thalassemia and has gone into portal hypertension, probably because of the iron deposition in the liver causing a liver cell failure.
Dr. Mujna, can I comment?
Yes, Dr. Sana.
Dr. Mujna, with that massive splenomegaly in the Wien-Harris, there are 5 common differential, but which one should consider. That will start from the order of preference according to the rest of the finding. But these 5 are the Kala Azar, chronic malaria, leishmaniasis, this Kala Azar.
That's Kala Azar.
Yeah, same CML, and then portal hypertension.
Yeah.
So one of them, I think I'm missing it.
Hereditary spherositis is also one of the causes, and autoimmune hemolytic anemia is also one of them. Not massive, but at least moderate it will be.
So because it is I'm saying it is massive because it's crossing the umbilicus.
Umbilicus, yeah. But portal hypertension will essentially have ascites with it.
Yes. So on the top, you should consider as portal hypertension. Then you can consider like chronic malaria, tropical, and CML.
And we can say that we are not considering this because of the ascitic factor that is there.
Exactly. Yeah.
But CML will not come in this stage, right? I think mainly we can consider Gaucher's, which comes with splenomegaly mainly.
No, hepatosplenomegaly Gaucher's comes with.
Mainly spleen comes, and splenomegaly more than hepatomegaly. So we can consider Gaucher in this case, I think.
As far as I just read today, Gaucher's, I think both were given nose. But that's a possibility. Gaucher's should be kept as a possibility. Ascites puts it out.
Yes.
Hello. I have a doubt. See, in the hereditary spherocytis will present like this much splenomegaly.
No, that was the reason that we said that.
Yeah, 3 to 4 years, they almost all must have done the splenectomy because they will be. So that is not a differential.
See, we can say that this. I'm not saying that's a differential. I said, in fact, ascites. The first would be infectious causes. Put the common first. Infectious would be first. Even that goes out because of the ascites that is present over here. Then we can say there can be hemolytic anemias like hereditary spherocytosis in this, but still the massive splenomegaly and the ascites puts that differential also out. So we are actually left with only prehepatic portal hypertension in this case.
No, I'm not talking about this case because the second discussion was what are the causes of no ascites, only splenomegaly. So in that case, hereditary spherocytosis will not come.
First will come infectious.
Yeah, there is Kala-Azar, Sore disorders.
Kala-Azar, chronic malaria.
Yeah,
Epstein-Barr virus, more common in their country. We can first enumerate in Epstein-Barr because malaria, Kala-Azar is
such a massive
one. But Epstein is not causing too much massive hepatosplenomegaly.
Not such a massive one. It will be a soft like that typhoid wala infectious mononucleosis. Will be very
but malaria, Kala-Azar is there common in their country, and malaria will also present with this hemolytic type of anemia. In this case, I don't know whether it was jaundice was there or not.
No jaundice was there.
No jaundice.
Here we can put first is a case of this one portal vein thrombosis. As you are second, we can cause this Gaucher, and third we can cause this CML.
But CML in pediatric age group.
JML, sorry, juvenile myeloid.
Juvenile,
JML,
juvenile, yes, sir.
Juvenile,
juvenile you can, yeah, juvenile you can.
So anyone has any other comments? So she was telling causes of massive splenomegaly from Wein-Harris. Did she told all 5? I think infectious causes, she told Kala-Azar and malaria. And then portal hypertension. What else? Another 2 she told Dr. Muzna?
I told Kala-Azar, okay, chronic, that is called chronic leishmaniasis or leishmaniasis, okay.
Okay.
Beside that, I told you chronic malaria.
Okay.
And third is the tropical splenomegaly.
Okay.
Third one is the CML, the juvenile onset CML.
Okay. Another one is portal.
That is the portal hypertension. Yes.
Okay. This case we are done. Okay.